So our final speaker is going to really hone us into a practical use of implementation science. So Associate Professor Falade Nwulia, Associate Professor at Johns Hopkins University School of Medicine. So thank you very much, Sean.
Thank you so much for the introduction. So I'm one of those inpatient clinicians, and so this is going to be implementation science for the inpatient and for those that are on a budget. So for many of us in the room, I think it all starts with people. And so this story starts with Mr. A, who I first met in 2017. At the time, he was 23 years old. He had recently been diagnosed with hepatitis C in a drug rehab program and initiated injection drug use 4 years prior. When I saw him, he hadn't used in 3 weeks. History included marijuana, cocaine, MDMA, heroin, and ketamine. And because I like to get to know my patients, one thing that struck out was that he had this really close relationship with his grandma, which I also did, so we bonded on that. I prescribed hepatitis C treatment because I was an infectious disease doctor, and that's why he was here, and referred him to outpatient drug treatment because that's what we do in the US. We refer people to specialists. When I saw him back in 4 weeks, he had not gone to outpatient treatment. On exam, it was clear that he was using drugs heavily. He had track marks, he had open wounds. And when I got his urine tox, it was positive for amphetamines, benzodiazepines, cocaine, morphine, and cannabinoid. And I remember thinking to myself, I know that I can cure him of his hepatitis C, but I'm not sure he's going to live long enough to benefit from that cure. And that was further heightened when his mom, who was at the appointment, turned to me and said, he will not go anywhere else for care, but he will come here. I will bring him for every appointment. Please treat his substance use. At the time, as an infectious disease doctor, I knew very little about treatment of substance use. And like many in the room, I asked myself, what do I do now? Interestingly, 2 weeks before then, someone had come to me and they were like, Sean, I know you implement programs. Are you an implementation scientist? I'm like, what is implementation science? And so what I came to learn very quickly is that implementation science really is just ensuring that these evidence-based interventions that have been proven to be efficacious in these extremely controlled settings are integrated systematically into routine clinical care so that people that can most benefit from those interventions have access to them. To do this, we need to identify contextual determinants. And that helps us to guide our implementation process and really translate knowledge of effectiveness of these interventions into real-world settings. In our approach to choosing and testing implementation strategies, it is important that we engage key stakeholders, the people we're trying to serve, the providers, payers, system leadership. And although we tend to focus on efficacy and effectiveness, there are other outcomes that are maybe even more important: acceptability, adoption, appropriateness, whether the system can afford it, feasibility, fidelity, and I think very important, sustainability. Too many programs are implemented through research projects, the research project ends, and the program is gone. And so, from my context, the problem was integrating substance use into infectious disease care. The evidence-based interventions we had, buprenorphine and methadone, very effective for opioid use disorder, extended-release naltrexone, effective for alcohol use disorder. But I care for patients in the US. Healthcare is very siloed. I joke that if you need a doctor for your left toe, you're going to need another doctor for your right big toe. In our specialty practice, it's an academic multidisciplinary ID clinic. It's in Baltimore. It provides HIV, viral hepatitis, and general infectious disease care. We provide care to over 4,000 patients. A third of our patients living with HIV acquired HIV through substance use and injection drug use specifically. We have on-site phlebotomy, point-of-care HIV and hepatitis testing, psychiatrists, case management, pharmacy services. And in my choice of an implementation science framework, I chose one that we don't hear of as much. It's the Chamberlain stages of implementation completion. And I say this to make it clear that there are more implementation frameworks beyond the CFIR alone. This framework is, I think, especially ideal for this context because we're observing and ensuring that we are tracking completion of key implementation stages. So pre-implementation, we want to make sure we do engagement, feasibility assessment, and readiness planning. During the implementation phase, we're ensuring that we hire the appropriate staff and train them appropriately. We're ensuring that we have ways to monitor fidelity. We begin services, and we continue to monitor monitor fidelity to ensure that we're providing the best services possible, and we also want to have a plan for long-term sustainability. So for our program, this was a clinic, there was a need, there are patients that need substance use care integrated into HIV care. This is a clinic issue. Who are the key stakeholders? I went to the clinic leadership and I said, this is an issue. I went to the clinicians, do you think it's an issue? I went to other staff, do you think it's an issue? Everybody's like, yes, this is an issue, we should do something about it. And they're like, where are we gonna get the money? And everybody looked at me. Clearly, we needed to find a funding source. The hospital was not going to cover it. The clinic was not going to cover it. But one of the clinic leadership actually identified a grant that we could apply for. It was a SAMHSA grant, that's Substance Abuse and Mental Health Services Administration. It's not a funding mechanism I was familiar with at the time. We got the grants. We're like, great, how do we implement? Yes, fast to fail, like Margaret was saying, we needed to implement quickly. We did a needs assessment. We essentially did a quick review of the literature to identify barriers that had been previously reported. We thought about our context and what likely barriers there were. We put a survey into Qualtrics, and the clinic manager sent it out to all the clinic staff. The clinic director donated a $100 gift card that people that completed the survey could be in a lottery to win. Based on what we identified as barriers, we created the initial model and then did feasibility consideration. And as part of readiness planning, we didn't do the full process mapping, but we did think about the workflow in our clinic. We did think about the opportunities to integrate screening, the opportunities to integrate treatment, who would be doing that, and how we would do it in a way that it did not disrupt the workflow of our clinics. Here is a table from a paper we've since published looking at assessment of barriers and facilitators. A couple of things stick out. So in the US at the time, to prescribe buprenorphine, you needed to complete buprenorphine waiver training. So 8 hours for a physician, 24 hours for an NP or PA in the US. At the time, only 20% of providers had ever completed the training. When we think about the comfort level, only 21% of providers said they felt comfortable managing substance use disorders. And when we asked providers, are you confident in your ability? When we asked providers, do patients with opioid use disorder in this practice receive the same quality of treatment for their disease as those with other chronic diseases like type 2 diabetes? Only about a third thought our patients were receiving quality care for their opioid use disorder. And when we said, what are the primary barriers, or what would be a facilitator, by asking the question, I need more training in order to provide better treatment to my patients with an opioid use disorder, 82% of patient providers said they need more training, right? And so the barrier really seemed to be lack of support and lack of training and comfort with opioid use disorder care. And so in our choice of implementation strategies, we focused on what we think were actions that would increase adoption of implementation and sustainability of the evidence-based intervention. And so it's always important to be really clear about what your evidence-based intervention is. So for us, it was buprenorphine for opioid use disorder treatment. And so we really focused on strategies to overcome the barriers of limited comfort with and lack of support for substance use disorder care. Implementation science is all about the lingo. It's frameworks, the ERIC strategy, and I know for the uninitiated it may seem overwhelming, but trust me, it's not that bad. The ERIC implementation strategy, as Guillaume already mentioned, they've already compiled on the implementation strategies for us, right? It's really about identifying the implementation strategy that's best to overcome the barriers. And I put in there just a snippet of the 73 strategies that have already been identified. You always need implementation staffing. So for our project, we had a clinician champion. This was an experienced HIV clinician who honestly at the time had very little substance use disorder care experience, but wanted to make a difference, was like, pick me, I want to make a change. We hired 2 peer recovery specialists, community members with lived experience of substance use, who we integrated as full members of the medical team and trained in motivational interviewing so that they could best support our patients, both with that additional clinical training and their lived experience. Because we had very little substance use disorder care experience ourselves, we looked for additional supports, and that came in the shape of an addiction psychiatrist and a therapist who were already in the clinic providing psychiatric care. And we looked for additional supports in the community. At the time, Baltimore had a hub and spoke model where we already had opioid treatment programs who are specialist addiction care providers who made themselves available to spokes, people like us in the community who wanted to do substance use disorder care but didn't have much experience. So they mentored us. And we also had workflows for easy transitions to higher levels of care for patients that we really didn't feel we were doing as good a job with in meeting their needs for substance use disorder care. And so this is a table of our implementation strategies. We called our program Restore, Come Get Restored in the Bartlett Clinic. It's a peer-facilitated model for integration of low-threshold substance use disorder care into an infectious disease outpatient setting. Our initial pilot was funded by SAMHSA. The strategies were training. We were able to engage with the clinic leadership, and they allowed providers to have a half day off so that everybody could go to a free on-site buprenorphine waiver training. In addition, we also made online resources available to providers so that in their own time they could learn more about how to provide substance use disorder care. And then quarterly at the HIV Provider Conference, we would have a case discussion and some didactics so that over time providers could build their comfort and their capabilities related to substance use disorder care. There was ongoing local technical assistance provided by the ID provider. She had support of 50% of her salary to, 1, lead implementation of integration into the clinic, 2, have time to get additional training in substance use disorder care so she could provide care and also be an ongoing source of local technical assistance for other providers in the clinic. To engage our patients in care, our peer recovery specialists were trained, and there was an expectation that they would engage with each of the patients in the program at least weekly. And for monitoring, there was a weekly team meeting where we had fidelity logs to ensure and check in on if the program was being implemented as intended. I want to recognize Tracy Agee, nurse practitioner that I work with in Baltimore, who is tireless in her efforts and who we've done a lot of this work together. So for the implementation phase, I already shared that we had ongoing fidelity monitoring through our program logs. We were able to start the program within 4 months of funding. We advertised at clinic meetings, and we set up the program to be as low barrier as possible. Any member of the clinic could refer. We had a phone that you could call and you would reach a peer immediately, and our peers would immediately go to where your patient was. I cannot tell you how many times I've had patients in a room and a peer walk in and introduce themselves as a person with lived experience, and they just open up in ways I have never previously seen those patients open up. At our weekly meeting, we review logs and processes to assess fidelity to implementation. To evaluate our outcomes, we use the RE-AIM framework, so another implementation science framework, which is known primarily as an evaluative framework. So the domains are REACH, which really measures the number, percentage, or representativeness of eligible patients who participated in the intervention. And so REACH is trying to answer the question, is the intervention reaching the target population, so those most in need? Effectiveness, we're all very familiar with effectiveness, the intervention effects on targeted outcomes. Adoption, the number, percent, and representativeness of participating providers. So to what extent are those targeted to deliver the intervention participating? Implementation, the extent to which the intervention was consistently implemented by staff members, and then maintenance, the extent to which an intervention becomes part of routine organizational practices and maintains effectiveness. In the first 2 years of program implementation, 258 unique patients were referred, 182 engaged in substance use disorder care, about 71%. And to do our outcomes evaluation, we did have a separate survey, and only 75% consented to have their data used in research. So here's a description of the characteristics of those that consented: predominantly male, a median age or mean age of 52, predominantly African American. About 11% of our patients were homeless, and majority of the patients that we engaged were living with HIV, very consistent with our clinic population. With regards to adoption, we went from 6 ex-waivered clinicians that could prescribe buprenorphine pre-implementation to 33 post-implementation. We went from 3 providers who had ever previously prescribed buprenorphine to 29 who went on to prescribe buprenorphine. 75% of clinic providers referred patients, and our peers had over 4,500 peer contacts, outreach, recovery support, coaching and mentoring, warm handoffs to higher levels of substance use disorder care in the community. And when we look at our effectiveness outcomes, the blue bars are baseline data and the red bars are 6 months after program participation. We see that patients had significantly lower rates of generalized anxiety. And look at the dates, 2009 to 2021. What was happening 2009 to 2021? COVID. Everybody's anxiety was going up. Our patients felt supported and we're doing better. With regards to ED visits, significant reductions in ED visits, significant reductions in hospitalizations. We had increases in HIV viral suppression and increase in the number of patients that were cured of hepatitis C. And when we look across substances, we see significant reductions in use of heroin, fentanyl, cocaine, and alcohol. And although that data is not here, we also did have significant reductions in overdose rates in patients that were in our program. I'm going to take it back to Mr. A because Mr. A was patient 1 in our program. He got cured of his hepatitis C, he got reinfected, he got retreated, but then his grandmother died. And I remember the team meeting when the peers were like, we're worried about Mr. A. His grandmother died a month ago. He didn't pick his refill. We're worried there's something going on. And the peers were like, we need to do something, we need to do something. And so they tried to reach his mom, who we had the authority to share information with. We couldn't. They put a note in the EMR saying, call us. We're worried about you. You're at high risk of overdose. His mom saw that note, and that day she was at heightened alert and kept checking on him at night every 3 hours. She found him down with an overdose. She called the EMS. He was in the ICU for 3 days, but he survived. The power of peers, the power of community, the power of integrated care. When we think about acceptability, again, we have measures. Simple measures. One of them is the AIM, FAME tool, which you can easily use to assess. So basically, you have the question, I approve of ... your program. I think the ... is appealing to our patients. So very easy to use these tools. And what we have here are the proportion of people that strongly agreed or somewhat agreed with these measures. These surveys were done with clinic staff, and you see broadly we have high acceptability with a mean score of 16.4 out of a total of 20 for acceptability, and high appropriateness with a mean score of 17.9 out of a total of 20 for appropriateness of implementation of this intervention in our clinic. To assess implementation deeper, we use qualitative measures, and these are quotes from providers. We purposefully sampled for people that prescribed and those that did not. You see a provider saying, I like the process because it is an immediate engagement. It's an immediate connection with follow-up scheduled right there and then. Speaking to fidelity, that's what we wanted, right? But then we have another provider saying, so I think it's feasible for sure, but I think we'd need longer visits and support on the back end from programs like Restore. So if the HIV provider is also the substance use treatment prescriber, I would say the legwork, following up, paperwork, all the logistics will need to be supported by someone other than the prescriber, really speaking to not really overcoming all the barriers to adoption of substance use disorder treatment and more work needing to be done. From the perspective of patients, I was fortunate to have Emily Zhang, a master's student, do her capstone project, doing qualitative interviews with some of our patients. And when you look at the domain of reach, you see that the program reached patients with a wide range of prior experiences with substance use disorder treatment. With regards to effectiveness, beyond reductions in substance use, we see that patients reported reduction in urges to use substances. I don't urge for the street dogs. I do not urge for none of that. But I think even more importantly, we see other outcomes. This patient said, I can get up in the morning without my brain saying, go get a drink or go get drugs, and my kids are so proud of me now, and it just encourages me to do more. The mechanism of effectiveness, The consistency of staff team members really stood out. They are very consistent about how they do things and how things are run. I really appreciate that. And that shows me that they're not only working hard, but they're working hard in my best interests. In our quantitative data, when we asked what was the most important component of Restore, what we heard was knowing that someone cares. I'm out of time, but high acceptability, high appropriateness, and I will say that 2025 funding ended 3 years ago. The program is sustained up to now because the clinic sees value, the clinic owns the program, and they've found funding for the program. In conclusion, implementation science framework supports systematic implementation and evaluation of programs in clinical settings. We are all implementing programs all the time. We all need to learn from one another. Please disseminate your implementation findings. And when you disseminate them, it's really helpful to use the same language for the strategy you use, because then that allows us to understand which strategies are most effective so we can learn quickly from one another. I want to thank my patients, to the Johns Hopkins ID Division and Bartlett Clinic leadership, and the faculty and staff at the Center for Substance Use and Infectious Disease Care Integration that I do all this work with, and SAMHSA that funded our pilot and gave us a program that we have sustained till now, and all of you for being here so late in the day. Thank you.